No problems.
So Dr. Vishal Janji needs actually no introduction. He's from RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences. Sorry, he did his MD from RP Center, AIMS, New Delhi, and now he's working as professor in University of Pittsburgh,
Thank you.
USA.
It's always nice to be introduced as a RP Center boy. And I don't know if Dr. Namta knows, my badge says Ludhiana, so it's actually even better. It doesn't say USA. All right, my presentation is going to be on ocular GVHD. I don't have any financial disclosures relevant to this topic. Um, so this is what I'm going to cover: overview of GVHD, current treatment options, new treatments on the horizon, and prevention if it's as possible. Um, it's a really, well, I would say it's a relatively fresh topic for ophthalmology in many parts of the world. Folks who are working in hospitals and clinics that are associated with the bone marrow transplant centers, cancer centers, if they don't know already, they should be prepared for this epidemic of patients. The more we know, the more we learn about these patients, the better it is. So basically, what happens in graft versus host disease in general, that it's allogenic hematopoietic stem cell transplantation, or LOHSCT. It's a standard treatment of choice and a successful treatment for many hematological conditions and oncological conditions. So, which means that you already have a treatment for these patients who would otherwise, unfortunately, won't live long enough. And unfortunately, despite all the immunosuppression, a bunch of these patients, they develop what we label as graft versus host disease. Acute GVHD, it's T cell mediated. That's basically a no brainer after you do a bone marrow transplant. Happens typically in the first 100 days. Ocular involvement is fortunately not very common, although 7% doesn't sound like a very low number, but wait until you get to the next slide. The important thing to remember is that if somebody has acute GVHD or GVHD with in the acute stage with ocular complications, it's actually a prognostic factor for higher mortality. So you really need to be aware of this. Common ocular symptoms are only eye pain and excessive tearing. So it's difficult to diagnose, but one of the reasons is that there's so much happening in acute GVHD, not ocular GVHD, in acute GVHD, that people really don't care much about eyes for a good reason. You can see conjunctival involvement in hyperemia, chemosis with a membrane symblepharon formation, and sometimes corneal ulceration. It also depends on the general systemic condition of the patient. Now, chronic GVHD, on the other hand, is a completely different ball game. The pathophysiology is less understood. It's probably a CMI, complex immune-mediated disorder. Look at the percentage of ocular involvement. It happens in 40 to 60% of patients with chronic GVHD. And these are the patients that we would most likely end up seeing in our subspecialty clinics. Common ocular symptom is dryness of the eyes. So again, dry eye, but not your garden variety dry eye. Most patients will have intense dry eye with photophobia. Three important processes are happening in GVHD, ocular GVHD: lacrimal gland dysfunction, meibomian gland dysfunction, and corneoconjunctival inflammation. Less commonly seen, but certainly not to be ignored. Symptoms include scleritis, uveitis, vitritis, retinal hemorrhages, cotton wool spots, and serous detachment of the choroid as well. So very important when you see a patient with GVHD, always look at the fundus. You don't need to dilate them every single time if you know them for a long time, but you cannot ignore fundus examination in these patients. So patchy corneal staining is very commonly seen. A dry eye that is unlike your routine dry eye. You can see filaments that are larger than usual filamentary keratopathy, and of course there is a huge dropout for meibomian glands. So as I mentioned, these are some of the pictures. You see the corneal staining is actually quite patchy. Some of the places where you see staining, they ultimately develop anterior corneal haze. You can see this photograph here on the extreme left, my left. The staining actually is taking the shape of epithelial hypertrophy. As I mentioned, there's a lot of corneal conjunctival involvement. Inflammation, basically, this is the leading cause of symptoms in patients. You see this starry sky staining of the conjunctiva. You see a lot of filaments in these patients. One of the things that is very unique to ocular GVHD is erosive tarsal scarring. So this picture doesn't show erosive tarsal scarring. This just shows scarring which has happened because of meibomian gland dropout. You would expect to see a picture like this, especially in a place like India, if somebody had trachoma in the past. But in GVHD, you see this at very early stages of chronic GVHD. So again, very important to avert the eyelids. You can see corneal scarring. This is a patient who had massive corneal scarring and corneal neovascularization and ultimately needed a penetrating keratoplasty. Corneal epithelial defects. This is one of the worst patients that we saw a few months ago. This is the first presentation. Patient was quite unwell, had chronic ocular GVHD, and was on a lot of immunosuppression. We made serum eye drops for the patient. Patient never came back for follow-up. He unfortunately passed away. So there are times that you will see the patient only once in their lifetimes. Treatment, it's important to reduce ocular surface inflammation, to prevent cicatricial changes, and a multidisciplinary approach is very important. Prevention of tear evaporation should be achieved by warm compresses, lid hygiene. You can use topical erythromycin ointment. Macrolides work very well, especially in meibomian gland dysfunction. You can use systemic tetracycline, doxycycline, and minocycline. Some of these patients, they are really fed up of having too many antibiotics, so it's not always easy to convince them to have another pill. You can use moisture chamber goggles for some of these patients. Lubrication and preservation of tears is equally important. We always use preservative-free artificial tear drops. You can use acetylcysteine to treat filamentary keratitis. Oral secretagogues, we use a lot of pilocarpine or cevimeline. They are, of course, limited by their side effects. Some patients are really, they're having a hard time. The maximum dose is 5 milligrams 3 times a day. We try and stick to 20% autologous serum instead of 50%, just because once you use 50%, you're giving more TGF-beta to the ocular surface, which can cause more inflammation. Scleral lenses, they can be life.
Because this case was my case. So the feeling is totally different when you meet your case with this problem. But finally, I will show in this presentation how to be careful when you diagnose ectasia, because many cases you may find the signs of ectasia, but actually they are not ectatic disorders. Let's start with the case 1. 38 years old female, past history of LASIK OU 2 years ago by me. On the last visit, which was 1 year ago before presentation, the unaided visual acuity was 6 OU, and the patient was so happy as shown in this reaction. But on this time, on this date, July 2019, this patient came to my clinic with panic and depression with rapid drop of the visual acuity. The unaided was unbelievable. The unaided visual acuity was just 160 in the right eye and 360 in the left eye. The best corrected with the unlogic refraction was 260 and 660 in the other eye. This was the manifest refraction -8, sphere -9 cylinder, and in the other eye -4 and with -5 cylinder. Normal intraocular pressure, and the fondi very minimal key piece, which was very, very minimal, down to be insignificant, with almost clear corneas. I was asking at this time who switched off the room light. It was a horrible moment. I could take this photo by a street lamp through my mobile for the cornea at that time. If you look at this cornea, you will find no abnormality could be detected on this photo, especially after the refractive laser-based refractive surgery. You may find some infiltrates, very fine infiltrates may be present in the bed. So it may be insignificant in this case, but in other cases could be of significance. I sent this patient immediately for corneal imaging to get this pentacam, I found that there is a very significant inferior steepening in the center part of the cornea, and found this picture which will give you impression of ectasia at the first moment. Actually, the assistant doctor who made this investigation came to my clinic, to the side clinic, while she is very sad and saying, while she is crying, "Sorry, doctor, she is ectasia." And I had on that day one of my professors present in my center who said the same. It's ectatic disorder, and it's post-LASIK ectasia you have to deal with. I was shocked on that time, but when I went back and sat on my seat and thought for a moment, how to be with this steepening in the center cornea with this thick cornea. The pachymetry, when I went down to the pachymetry, I found that the ectatic part of the cornea and the topography is the thicker part. So it should be other thing than the post-LASIK ectasia. I have to think again about that. I found that the thinnest allocation is 539 and up to 669 in part of the center of this cornea, with a very normal back elevation, with a very normal the same pattern of the pachymetry map coincides with the normal part of the posterior elevation. So it's not ectatic disorder, and I will think again about this case and follow her up. But the key here that this patient with past history of cornea refractive surgery. So the first thought to rise in your mind with this picture that it should be an ectatic cornea. But you have to think slowly. You have to think. Don't be hurried to diagnose, but you think, and you have to review every single point in your imaging very thoroughly and carefully. And this is the other eye, the same pattern, but somewhat later than the first one. And I got this specular microscopy and the anterior segment OCT for this patient to find this. The subjective refraction is very far from the manifest refraction, and the cornea is thick at the ectatic part, and also the corneal endothelium as well. I was thinking in the corneal edema. So I like to check for the endothelial status for any reason to decrease its function with corneal edema. So the best corrected was 636 with this manifest refraction. The treatment in that time I thought to deal with as a case of unknown corneal edema until I can find the cause. So I started this time with the normal saline, sodium chloride 5%, the prednisolone, and copious lubricants. But unfortunately, after 5 days from this treatment, the patient called me that she is worsening, not improving. So I asked her to come to the clinic and found this presentation, found these changes in the cornea. The center corneal opacity shown in these pictures, as you see, it's not related to the total cornea, but just the central part. So this case with the central corneal edema due to an inflammation, either to be autoimmune or to be interstitial keratitis after herpes, herpetic uveitis or herpetic keratitis. So now the mind is changing, viral or autoimmune. I start first with carefully to be away from the deterioration of the virus if it's present. So I choose on that time to start with the oral acyclovir and topical ganciclovir, fluorometholone, very little dose of the fluorometholone, and immunomodulators. And after 10 days, I found no response. So turned to the other option, which is an autoimmune disease. So turned to aggressive autoimmune therapy together with a consultant of autoimmune disease to start a systemic therapy with injectable methotrexate oral prednisone, 100 milligram per day in Solipred, the topical hydrocortisone, and primidine to control the intraocular pressure. And after 2 weeks, we found a marvelous improvement. So this picture is for Pentacam for this patient after around 1 month from starting therapy with much less corneal thickness and much less Kmax. As I show now, in the first one, the thinnest location was 540, and now it's 510. And finally, you will find that the Kmax, it was 56, now it's 54, starting to be less in both eyes, the same eye, the other eye the same. The Kmax was 51.3, now it's 45. The Kmax decreased around, is reduced around by 6 diopters, and the thinnest location was 540, now it's 520. 3 weeks more, there's a marvelous improvement in the features shown in the Pentacam. And finally, this is the picture of her cornea again, like the first presentation, with unaided 612 and 609, almost clear cornea. And she restored her vision and mood wellness, and me too. This is the first case, which was a horrible case. I have learned a lot from this case, to think about other things and to take care and pay attention to every single insignificant point which can I find in the patient. I didn't care about the very minimal key piece on presentation, but actually, if I pay this attention for it at the first time, I would manage her in different way from the start. Let's go for the second case if I have time. This patient came to my clinic seeking for refractive surgery. She's a 26 years old female with a very, very low visual acuity, and she refuses to wear the glasses to correct her vision. This is the Pentacam. I will show the clinical data and went back to the Pentacam. The clinical data for this patient, the right refraction was -1 sphere, -8 cylinder. The left eye, almost the same. The unaided, less than 360, and the best corrected is 624, and left eye is 618. The IOP is normal, clear lenses, and normal fundi. Let's go back to this Pentacam. When you look at this Pentacam, you will find that this is a very steep cornea. The key one is 47, the key 2 is 54, which is totally out of normal. So this Pentacam is showing that this patient is conic, but look at the Pentacam, the steepening is present superiorly and inferiorly at the same time. Also, it's almost equal, superiorly and inferiorly. It is not the pattern of the keratoconus. Even the central nipple cone, it will be shown in different category and different features. So look at the back. The back is still normal. And I'm believing there's no keratoconus without back changes at all. I didn't find any way in my life that there is no keratoconus without posterior changes. The keratoconus, the posterior disease before being anterior disease. and it's proved now by epithelial mapping, which help diagnosis of the very early changes in the epithelial thickness with complete anterior surface and changes in the back, which will be shown in the changes of the epithelial behavior. So many surgeons before coming to me refused to do some refractive surgery for her, and they couldn't diagnose her as a keratoconus. The issue is here in this picture. You will find that there is a circular, extensive corneal degeneration, which make this cornea looks like the cornea ablated for a hyperopic correction. You will find a very deep center, a very steep center with very flat mid-peripheral cornea. So the corneal degeneration did this changes, like a thinning in the mid-periphery causing a counteracting steepening of the center cornea. So this cornea is not keratoconic at all. This is the other eye. And so, what's the diagnosis in your opinion? Is it keratoconus? I said no. Then, what to do? My diagnosis is pterian margin degeneration versus advancing peripheral corneal degeneration. The pterian margin degeneration with actual thinning, not just degeneration, which will be marked thinning in the cornea, so it's not pterian margin degeneration. So my final diagnosis is that it's advancing, strange, rare cases of advancing peripheral corneal degeneration, like shown in this image. Thin body with a normal head. This thin body will show that head is larger than normal, but it's still normal, with a normal circumference and measurements. In your opinion, how to manage this case? Would you do a refractive surgery for her? Would you do customized ablation procedure like topo-guided or Refran-guided ablation or others? Upon myself, I have done a customized ablation for her with a very good outcome. This patient could see much better than the glasses, around 6/18 unaided, and she's stable until now after 3 years of follow-up. So don't let the papers to deceive you. You have to pay attention to the clinical presentation and every single point in your data before going to the diagnosis. And thank you so much.
Thank you so much for that lovely presentation.
My pleasure.
My
pleasure.
Can you please join us on the dais? I would now request Dr. Vishal Janji to give his talk on keratoconus, diagnosis and management.
Okay, all right. So thanks so much. So I have a lot of slides, but I'm going to rush through a few of them. This is a very general overview of keratoconus. I'm going to try and present some what we already know and some of the new things that are in the pipeline. Don't have any financial disclosures. Everybody in the room, I'm hoping, knows what keratoconus is, characterized by central or paracentral corneal thinning. Varied presentation from a normal-looking cornea to a cornea with extreme thinning or corneal scarring. Now, we already know that keratoconus is associated with decrease in the number of collagen fibers. There is slippage of these collagen fibers, and those bridges are broken, and that's where the treatments will come into play, which we'll discuss in a bit. Clinical presentation, as I mentioned, is usually starts early. I'm sure people who have access to corneal tomography, they have realized that the age at diagnosis is decreasing. And that's not because keratoconus is becoming more common in kids or in younger patients. It's just because we have become better in picking up keratoconus at an early stage, which is really a good thing. Early signs are both stria and Fleischer's ring, and late signs can be Munson sign, Vazuri sign, and corneal scar. Diagnosis, many of us in this room started with VKGs or even something before that. But by the time the disease appears on VKG in the anterior float, you've already missed a few things. OBSCAN gave us an opportunity to start looking at the posterior float, and then more and more papers came out looking at the importance of looking at posterior float for diagnosis of keratoconus at an early stage. Scheimpflug imaging, with or without combined placido disc, has basically revolutionized the diagnosis of keratoconus, specifically by its ability to look at the posterior float. You can have any number of presentations, especially if you look at the pictures from Pentacam, central cone, inferior cone, which is most common. You can have a pellucid-like picture, or you can have a displaced cone. But are we diagnosing them early enough? This is a swept source OCT from Tomei showing a normal-looking cornea with average Ks of 42. If I ask a refractive surgeon in this room, would you do LASIK on this patient with a corneal thickness of close to 600 microns? You would probably say, yes, I'm going to do LASIK. And there's an ectasia screening program which shows that there's a 0% possibility this is a keratoconic cornea, unless you're looking at the other eye. This is a normal pentacam for the same patient. The other eye of this patient actually is florid keratoconus. So the first eye is now labeled as form first. Now, if I ask you the same question, would you do LASIK on the other eye? The answer would clearly be no. This is another patient with normal looking pentacam, and other eye has keratoconus. Another patient who has arterial tortuosity syndrome, which is associated with corneal thinning, but fortunately no corneal ectasia. So very important, as the previous speaker also said, it is important to distinguish ectasia from normal corneal thinning. Non-tomographic diagnosis is what we rely on more and more nowadays, using wavefront aberrations, corneal biomechanics, FTIR, and optical quality analysis system. I'm just going to focus on corneal biomechanics a little bit. We have ORA and Corvus ST available commercially that can be used to measure corneal biomechanics. We have been using Corvus ST for more than 10 years now. It basically captures corneal deformation response, and more than 4,000 images are captured per second. The puff of air basically indents the surface of the cornea, much like NCT, normal non-contact tonometry. And then there's an inbuilt software that measures the response of corneal deformation to that puff of air. We've shown that the repeatability of a corneal deformation response is actually pretty high in normal as well as keratoconic eyes. A relatively new index called Corvus Biomechanical Index. It basically combines a few indices that we can pick up from Corvus with sort of highest regression number. And then you can have one index, which is called CBI, which helps in early detection of keratoconus. It's use of AI-based software to detect cases at an early stage. And again, a relatively new software in the same machine, which combines the BAD from Pentacam or Scheimpflug imaging and Corvus, gives you another index called Tomographical Biomechanical Index, or TBI. This is the same patient that I showed you earlier, where we thought the eye is normal and the contralateral eye had keratoconus. But if you do a CBI, it's actually 1.0. Anything more than 0.5 or so is regarded as abnormal. So here showing that CBI has an ability to pick up disease at an early stage, when corneal tomography would not be able to pick up the disease, and specifically TBI as well. In this patient, TBI is more than 0.75, showing that it's abnormal. So to conclude for this part, it is important to diagnose keratoconus at a very early stage. If you have cases with form first disease, where you know the patient definitely has keratoconus because the other eye is keratoconic, it is important to follow up those patients just for the sake of research and see how these patients progress. This can be a useful tool in refractive surgery screening and for proper selection of cases for cross-linking. In terms of management, we have been managing keratoconus for more than 150 years. All these modalities, they treat the keratoconus, but they do not change the basic disease. And the biggest example is when we do a corneal transplantation and the patient sees better. 15 years later, the patient comes back with keratoconus or corneal ectasia beyond the graft-host junction because you left that frill of keratoconic cornea in that eye. This is good old days. We published this in BJO in 2011, and you see all the options, they end up in keratoplasty. Times has changed now. New goals of management include halting progression of the disease and then visually rehabilitating the patients, specifically by using collagen cross-linking, which, if you remember my slide earlier, increases the number of bridges on those collagen fibers in the cornea and frame shifts the biomechanical properties to a better level. Especially in India and mostly in Asian continent, we have to realize the importance of avoiding a corneal transplantation. We hardly have any donor tissue. So cost effectiveness of cross-linking as compared to transplantation has been shown to be hugely better, and there's a reduction in need of corneal transplantation. This is one of the first randomized controlled trials in the world on cross-linking. I was fortunate enough to be present in Melbourne when this happened, basically showing that at 3 years down the line as compared to controls, there's a significant reduction in Kmax and improvement in uncorrected visual acuity after collagen cross-linking. For those of us who are doing collagen cross-linking, there are multiple presentations this morning. There are different iterations of the technique. You can do a conventional cross-linking, takes a long time. You can accelerate the process by increasing the energy and decreasing the time. You can also perform cross-linking in thinner corneas. The recommendation is not to touch the corneas less than 400 microns. This is a study basically showing that there's a differential response to treatment depending on how steep your cornea is preoperatively. So if your corneas are very steep, more than 58 diopters Kmax, you're going to see massive flattening. So these patients actually, they see an improvement in uncorrected visual acuity after cross-linking as well. And this is a patient with pre-Kmax values of 46. And 1 year down the line, there was a flattening and improvement in best corrected visual acuity. Another patient who had steep Ks of 59 diopters preoperatively, and 1 year down the line, the patient had 55 diopters steep K, so about 4 diopters of flattening. Another patient with massive flattening in the central of the cornea. You can see preoperatively that readings are 73, 70.7, and so on. And a year post-op, the patient is in 60s. So patients are very happy. Their uncorrected visual acuity improves. As I mentioned, you can change the protocol to high fluence or accelerated cross-linking. To 30 minutes at 3 is what we do usually. You can change it to 5 minutes at 18 or 3 minutes at 30. There's only one paper in IOBS published that shows that you should not try and not go below 10 milliwatts per centimeter square if you want to see adequate impact of cross-linking. We published a study about 8 years ago showing that there is actually no difference in conventional and high fluence cross-linking, except the flattening that you see in conventional cross-linking is about 1.6 diopters compared to about 0.5 diopters with high fluence cross-linking. A bit about transepithelial cross-linking. As I mentioned, there are advantages of leaving the corneal epithelium on, but we've shown in animal studies and now in human studies as well that transepithelial cross-linking, the flattening effect is not great unless you have a very steep cornea. So we repeated the same study in transepithelial cross-linking and found that if you have a steep cornea, you can still get adequate effect of cross-linking. This video basically shows a new software in Corvus. Basically, the red and blue corneas are pre and post cross-linking. And the difference in indentation, the CDR, corneal deformation response, shows the impact of cross-linking on these cornea. So really useful to have this device in your clinic. Quickly about keratoplasty, everybody in the room knows there are distinct advantages of performing a partial thickness endothelium sparing lamellar keratoplasty. Whenever possible, we try and do a lamellar keratoplasty, whether it's DALK, DLK, or LK, manual, femto, whatever you want to use. Try and not do a full thickness transplant because these patients are young. They're bound to have at least one rejection episode during their lifetime. DLK works very well. All studies, I was lucky enough to publish with my mentors from RP Center. Just to conclude, early diagnosis of keratoconus and timely treatment is very important to avoid transplantation, and you can use contact lens fitting, which I did not touch upon. Corneal biomechanics, they provide an avenue for enhanced diagnostics. A combination with corneal tomography, the BAD score and other score, it gives us an opportunity to look at the pathogenesis of keratoconus as well. Collagen cross-linking is a definitely promising technique, especially in younger patients where you can slow down or stop the progression of keratoconus at an early stage. And lamellar keratoplasty should be a definitive choice wherever possible for keratoconus instead of full thickness transplant. Thank you very much for your attention.
Can I ask a question? Thank you. Vishal, thank you for a very nice presentation, but I'd like to ask you about the recross-linking. Did you recross?
Yeah, so I haven't recrossed too much. You have to work at a place for about 20 years to see these patients. I can tell you, unless you're doing pediatric cross-linking, you might not need to recross-link them too many times. The usual time is about 5 to 7 years when you might need to recross-link them.
Yeah.
Yeah, so
okay.
I'm sure you probably have more experience than anyone else in Egypt with cross-linking.
Yeah. By which mean of investigation you can judge the corneal biomechanics, or you believe in the line, demarcation line?
Yeah, so well, we've stopped looking at the demarcation line now.
Yeah.
We don't care much about demarcation line because you can see the demarcation line after every cross-linking.
Yeah.
And the depth really doesn't matter because we already know that the demarcation line is deeper in conventional cross-linking compared to transepithelial cross-linking.
Yeah, exactly.
Yeah.
So about the recross-linking, it depends upon the stromal elevation or the stromal case to avoid the epithelial changes. Then it's available now in some device like the MS39. I have it in my center.
Yeah.
So I'm following this with the stromal changes, the stromal case, not the front case.
Yeah.
Because it may be changed by the epithelium itself. If
Sure.
there is change in this or change in the total thickness of the stromal part of the cornea, I will recross again.
Sure.
Otherwise, no.
Thank you very
Thank
much.
you. Thank you so much.
Thank you.
Thank you, Vishal, for that lovely lecture. Now, I request Dr. Hussain Zada to talk on obstructed delivery to wide or divide.
Thank you, Dr. Namarta. So my talk about obstructed delivery and during cataract surgery using the manual small incision cataract technique to wide or divide. When you have huge rocky nucleus, what do you do? To divide the nucleus inside or to make wider incision. This is the challenge in your case. Like this case, it was an obstructed labor. So I went for my Widrexes from the side port to keep the antechamber closed and deep, even without stain. Then doing the scleral tunnel 6.5 millimeter outside and the 9 inside. Look how the nucleus is big one and rocky at the same time. So the regular technique, which is this phaco sandwich technique by 2 instruments, is my preferred technique. I injected viscoelastic from the side port to make the endothelium away. Then I delivered it by the phaco sandwich. The scope alone is not enough in such cases. You have to take it in one shot by 2 instruments together. So I completed the case after that. This is one way. The other way is to make a smaller incision, and it is the era today in the small incision cataract surgery to make a smaller and smaller incision. Especially my preferred site of scleral tunnel external incision to be away from the limbus to avoid the surgically induced astigmatism. It's around 2 millimeters from the limbus. I don't like frown incision or to be closer to the limbus to avoid fish mouthing and to avoid the surgically induced astigmatism. In this video, I will show, after acknowledgement of my dear colleague, Dr. Dury, about this technique of very small incision around 4 or 3.5 millimeter with the scleral pockets on each side. This is the issue about the small incision, to make it smaller, and then you will manage your nucleus inside to be compatible with this incision. Yeah, now on this scope, I can divide the nucleus using the Sensky, using the system tip, or using any sharp instruments. And you can extract the nucleus either two halves, while on the scope they are in the same time as to be delivered in one time, while the two halves are put like sandwich on the scope itself. Or the idea of the 2 millimeter incision, manual small incision cataract surgery, which is founded by the Professor Amal Youssaho, the founder of the society, to make smart and sutureless, astigmatic-free corneal surgery by this technique. To define first the site of the incision, using the scope to know the preferred site for your incision to avoid the astigmatism, or to correct the astigmatism which is present preoperatively. Now we are injecting the local anesthesia, then very fine cautery, and avoid all the time to cauterize the limbs. Don't destroy and don't damage the stem cells, the limbal stem cells. So it's just 2 millimeter incision outside, with scleral tunnel longitude, with radial incisions on each side to do scleral pockets, which will be with no effect on its width, on the ocular tissues, and the refraction after that. Then the completion, you can make the internal port or internal opening of the tunnel wider as you wish. I will make it faster. My professor Amal Youssaho used to use the staining, but actually I don't. I'm just staining the white or very dense brown cataract. So you can do it without stain, using the ray reflex to your rhexis. In such a case, you can do your rhexis wider to deliver the nucleus easier. Yeah, this is very big CCC, hydrodissection. And then the nucleus delivery in the antechamber after opening of the scleral tunnel internally. So you will divide the nucleus either inside of the bag or outside of the bag, like in phacoemulsification, exactly. Then rotate to deliver each half above and put it in the direction where the scope can deliver it very easily from this very small tunnel and minute incision. I think the usual phaco incision is around 2.2, according to the phaco piece you used to use, but this incision got smaller than the phaco incision. Now the second part, and you have finished your procedure. Do the irrigation aspiration to remove the cortex from the side port, which is much better to keep closed system and closed chamber, to be easier for your aspiration, and to keep the posterior capsule always away from your instrument. Epinucleus is also removed using the Simcoe cannula. And after this, you will inject which type of IOL. From 2 millimeter incision, you can inject the foldable IOL like Infeco, even the premium IOL, the multifocal. If this patient is candidate for the premium IOLs, you can inject it with no problem at all. So take your decision before going to, if you have a big nucleus, either to wide or to divide. And if you could divide, it will be much better for your patient and for your outcome after that. And thank you so much.
Thank you so much for your fantastic lecture. And I think with this, we come to the conclusion of the presidential guest lecture. And I would request the people who are sitting on the dais for the next lecture to please come